Okay, so welcome to catheterization. As I've said, you can't do this until you're deemed competent. So I will come out and you'll do it manually with me, we'll practice. And then if you were to do this moving forward, you would do it under supervision of a nurse for up to 5 times. And then once the nurse signs you off, you're good to go. Okay, so this gives you the basics. Now, catheter is a hollow tube that is used to remove fluid from the body. And it's as simple as that. So we're just looking at extracting urine from the body. And obviously it removes and drains any clots or debris in the process. We've got 3 types of catheters. You've got your intermediate catheter, your urethral catheter, and suprapubic catheter. The 2 that you'll normally do is the urethral catheter, which is the indwelling where it goes through the urethra, either through the vagina or the penis, or suprapubic, which goes into the bladder wall. So it goes a bit like what you saw with the peg feeding. There's a hole there for the catheter to go in there. Different types of catheters. So the Foley, the tubey bit that actually goes into the urethra that comes out, you can either have a 2-way, a 3-way, and with those, you're looking at the ends. So at the end of the Foley, you've got a bit of plastic, and that's normally where you connect. And you've got the bit where you've got the plastic, and that's where we fill the balloon up. So that's where you put the water in. Again, would normally be prescribed by the gynecologist or the doctor. They would tell you which catheter to use. And obviously, we would just follow those instructions. So you can see here, you've got different sizes. So you've got female, male, 2-way and 3-way. So they'll be prescribed for you. That'll give you an idea. And you can see on here, you've got where you've got the, if we look at the top one, for example, you've got your green bit, that's for filling the balloon up. So that's once they're inserted, we fill that up with normally 10 mils of water. And that would pop it into place nice and tight. And if we wanted to flush the catheter or we wanted to put the bag on, then we use the opposite tube. So we use the big rubber tube for flushing, and then we use that one for filling the balloon up. So very much like that peg button, it's done in a similar way. So the catheter balloon is inflated with saline water for injections. And they normally come in the pack. So the syringes normally come preloaded with the right amount of water in which you're going to inflate the catheter with. We never use saline water because the salt in the saline can cause the rubber to deteriorate and burst. So you must always use the water that comes in the pack and don't use saline water. We know what the urethra does and what that's for, so we don't need to worry about that. So if we look at the female anatomy, you've obviously got your 3 holes. We're looking for the urethral opening. Obviously, vaginas look different on different women, and I know you probably know that, being ladies. The reality is you need to look for the urethral opening, and that can be quite difficult. So normally, for a female, you would have 2 carers managing this process, because as the lady kind of extends her legs out, you would have somebody separate the vagina so you can actually find the urethral opening clearly and easily. If, however, you put the catheter in the vagina by mistake, not a lot's going to happen, because obviously it's designed to take in space there. Where obviously the urethra, when you put that in, you'll know you've got it because it's a slightly tighter hole. And when you fill that balloon up, that it'll have traction on the end. Obviously, if you fill the balloon up in the vagina, it's just going to pop out. So it's not going to be the end of the world. As I said this morning, things that you need to consider when you're catheterizing people now is looking at whether or not they're transgender, because if they've got a designer vagina, it could be difficult for you to catheterize. And again, all slightly different. And if there's any FGM, so the female genital mutilation, so again, if the vagina has been tampered with in any way, that's going to make it difficult for you to catheterize. And in those situations, you would always do a refer on. okay, because it may need additional work going there. So cleaning or putting the urethra catheter in is a relatively simple, straightforward procedure. You can see here for the man, the urethra is slightly longer because the Foley has to go through the penis. You can see it goes past the prostate, so that's that lumpy bit there. And then obviously it goes into the bladder wall. And then once it's in, you can inflate the balloon and the Foley's in place. You can see on the female, though, actually, it hasn't got as far to go, has it? It's a little bit easier to catheterize a woman. And what you're looking for is the fact that the balloon sits quite comfortably in the bladder. Now, obviously, you're not going to be able to see that, but that's what we're looking for. Now, because this is an invasive care technique, it's important that you get consent. We can get consent 3 ways, written, verbal, or implied. So for this one, the implied might be that the gentleman gets his penis out, or the lady might just open her legs, and we would accept that as implied consent. Okay. We're not going to be doing that. We've done lots of that. So before we start, we're going to ask the customer if they can to empty their bladder content beforehand. We can encourage them to cough and try and urinate, and obviously make sure that the bladder is empty as much as it's humanly possible before we actually start any procedure. To determine residual urine in the bladder, so we need to know how much urine is in there, because again, once you put the catheter in, it could leak quite quickly. So you need to be worried about that. A history of any irritations, has there been an infection or any problems there? You need to bypass any obstacles. So if they've got an inflated prostate gland or something, that's going to cause you a problem. Obviously, looking at any of the drugs or anything like that, and just making sure you've done your bladder assessment beforehand. So going back to that paperwork and making sure that you're clear in what you're going to do. The idea is obviously you're going to need to measure the output in patients who are acutely ill or unconscious. So this is a reason to catheterize somebody. So if somebody is unconscious, then obviously it makes sense to catheterize them. Or if they're acutely ill, and actually it's a much safer thing to do. So thinking about the risk of somebody laying in bed, moisture lesions, you know, that could be a way that we do it. If they've got damage to their nervous system, so the control aspect of the bladder's gone, it could be a reason to catheterize somebody, because again, it could be difficult. Females can also empty their bladder prior to childbirth, so again, there could be things regarding that, and surgery, and obviously it avoids complications to the cervix and the womb. So again, if you've got people that's going in for surgery, etc., that could be a reason to catheterize as well. Things to think about is if there's been any trauma, if the customer's had a pelvic fracture, because obviously when you separate the legs, that could be quite painful. If there's inflammation around the urethra, so is there already an infection there? Is there any hematomas or trauma? And then obviously other assessments. And when we do an assessment, if you remember last week, we're looking, we're smelling, and we're trying to establish, does everything look okay if I'm going to continue on with this? So why do we catheterize the elderly? So we would normally do an indwelling catheter, should only be inserted after consideration of all other continence management alternatives. So have you done an incontinence diary? Have we looked at just prompting people? Have we looked at different pads and techniques? The reality is, if people become immobile, it could be a reason to catheterize them, because again, we don't want them sitting in urine for a long period of time because it causes pressure sores. If we need to monitor somebody, so if we're worried about renal functioning or other things, that could be a medical reason to catheterize somebody. Alternatively, if they are seriously incontinent all the time, that could be a good reason to catheterize somebody. The need to catheter should be reviewed regularly, and it should be removed if it's no longer needed. So we don't catheterize for long term unless, well, we just constantly review. So it would always be under review. So what are the advantages and possible risks of catheterization? So the advantages are it's non-surgical. You can do this. It's a very simple procedure. Oh, I've just copied that one. It can be removed after short episodes of care. So if it is just a short-term thing, somebody's come out of hospital, actually, it doesn't need to be prolonged period of time. Patients and carers can be trained to change catheters. So patients can do this themselves. And obviously, it's a much easier way to manage and monitor fluid. The risks of being catheterized obviously can cause bladder spasms, so that's muscular contractions. You can get leakage around the catheter site. So if the catheter and the balloon isn't put in properly, it can leak. You can get blood or debris in the catheter. So that's when the catheter bag fills up and it's slightly red, or you can see it's cloudy with all those bits in it. That would give you an indication that you need to flush it. You can cause injury to the urethra. So I don't know if either or any of you have had a catheter before. I have, and it was the most unpleasant thing I can quite honestly say in my life. And the pain is unbearable. It is one of the most painful things that I've ever had done. Obviously, it can cause scarring of the urethra. So if you don't put the Foley in correctly and you're jamming it, or the balloon slightly inflated when you're pulling it out, you can damage the urethra, because the urethra tube is quite small, and actually you're passing something through that's going to pretty much fill the whole urethra. So if that balloon isn't completely deflated as you pull it out, you can obviously damage the urethra. And the problem we have with people with dementia, sometimes they just pull them out. And if they're pulling them out, that's going to cause a problem, because again, that causes trauma and lots of bleed. And obviously 15 to 25%, so 1 in 4 people will normally get infections with them, because again, it's meant to be done aseptic techniques. And obviously if they're not cleaned properly and personal hygiene for catheter care isn't done properly, it's quite common to get infections. So risk of infections, obviously in the risk of insertion. So when you put catheters in, it is one of your aseptic techniques. So you must have catheter packs, you must have sterile areas, you must have your surgical gloves. It is aseptic, it is as sterile as you can get it. Obviously, foreign body, so anything that's got foreign body into the body, infection can travel, and that's why we always clean the tips of catheters and make sure they're turned off so the infection doesn't travel up. Obviously, the absence of a flushing mechanism, because you can't flush stuff out, so if you do flush stuff, it can cause a problem. And there's an opportunity for a biofilm, so if it's not washed properly, obviously it can become a breeding ground for bacteria. So our infection control procedures, aseptic techniques, and you'll do aseptic techniques when we do blood. So when we do the phlebotomy and venipuncture and wound management, we cover aseptic techniques then. So at this point, you just know that it's aseptic techniques. Obviously, hand decontamination and correct hand procedures and correct PPE to be washed. So, hygiene. The first thing we need to do is clean it daily. And again, when we clean, we go from the tip of the urethra and away. So the tip of the urethra and away, tip of the urethra and away, tip of the urethra away and away and away. So we clean inwards to outwards. Okay, so we don't clean into the urethra, we start at the urethra and work our way up. So if it's a vagina, we're going to start at the urethra and clean up. We don't clean down. And again, same for men. We would clean away from the urethra and then down the penis tip. And then it's a new swab each time. So each time we clean, it's a new swab. So we don't double dip, same cleaning as we go through. And avoid obviously creams and powders and things like that, because we know that that actually causes, talcum powder causes moisture lesions, and obviously creams will go into the body, so we don't want that. Leave the closed system alone. So obviously no unnecessary empty of the draining bag, so less touching of the time. We need to make sure when we secure and position the draining bag that it's not dangling on the floor, and we're avoiding cross-contamination and things going in. When we disconnect, we need to make sure that we're doing that in a clean way and avoiding any contamination. We should never be doing catheters with our bare hands. We should always be gloved. And what you tend to see, a lot of the nurses, they double glove. So when they wash the vagina or the penis, that's one pair of gloves. and they take off their second pair ready to do the procedure. So they're double gloved normally. You'll also make sure that you've got your changing and draining bags and equipment ready, avoiding cross-infection, and always clean before and after opening the catheter system. So the documentation in which you would need your care plan, which I showed you earlier, the reasons for insertion, so why are you changing the catheter? Is it a normal routine change, or are you changing it because it's broken or there's trauma there? You need to record how you got consent. It's really important because this is invasive care. You must record how you got the consent, not that just consent was given. So was it verbal, was it written, or was it implied? You also need to talk to them about the procedure and identify any difficulties. You need to detail the cleaning of what you did, the lubricant and the amount of liquid that you put in the balloon. So the rule of thumb is whatever goes in must come out. So if you put 10 mils in the balloon, 10 mils must come out. If 10 mils of water doesn't come out, re-inject the water back in and try and get it back out, because it might be that you've drawn out the water and it's stuck. So you must, whatever goes in must come out. So on your catheter packs, there's normally a sticker on the back of the catheters. One of those stickers normally goes in the care plan, if you had paper care plans, and you would write how many mils of water went in. If you've got electronic systems, then obviously you must write how many mils of water you put to inflate that balloon. Okay, and that's the reason, because when you deflate it and you pull it out, if you haven't got that full amount of water out, you can cause trauma on the urethra. So it's really important, what goes in must come out. Obviously, the sticker or whatever, and that gives you the batch number, the latex type, and the expiry date. You need to record how much urine came out. So as soon as you put the catheter in, you will get leakage, because obviously you put something into the bladder. So you can put a clamp on the catheter, so the plastic clamps, alternatively connect the drainage bag straight away. So as soon as the catheter is in, put a little kink in it, pop the catheter bag on, and then it'll drain straight away. And the reality is, if it doesn't drain, you're not in the bladder. So that's a problem. So you must get urine out. If you don't get urine out, abort and get somebody else to put it in. Okay. Obviously, detail the drainage equipment used. So what did you do? And then use their catheter passport. So catheter passport is an NHS document, and it lists everything about them and their catheter. I don't know whether you've seen those in your care homes. No. I think there is a document on here, the catheter passport. What I'll do, I'll make a note and I'll put it in your learning site, because it's useful for you to see them, because the catheter passport is what people use in the community and in other environments. So catheter passport. Okay. Oh yeah, there you go. That's the catheter passport. So the catheter passport looks at the hydration. So you talk about the quality of the urine. It obviously has the details of everything. It'll have an action plan, what to do if it goes wrong. And then you will know the catheter type, the catheter size, if there are any problems to be aware of, and then you get the steps to take. Okay, so that's what the catheter passport does. Equally, you could class it as the catheter care plan, but there must be a care plan. Okay. And equally in the passport, it does give you how to insert it and what to do with common problems. So the trial without catheters. So once you take the catheter away, obviously the bladder needs to be retrained, because it's not had to work, it's just had to leak, hasn't it? So if you are going to take the catheter out, you need to consider bladder retraining. And this is what we talk about, that continence management. Bladder retraining is a really useful thing. There's lots of videos and exercises online. So if you have got somebody who's got a weak bladder, bladder retraining is a useful nursing intervention. You need to think about the catheter tip and how the balloon interacts. So whether it's inflating, deflating. You look at the discoloration around the indwelling part. So that's any signs of infections. Any problems that you have with a balloon blowing up or deflating them. If the patient has any discomfort, you need to report it, because again, that could be a sign of infection. Any bleeding, you would report, because again, risk of infection. And the urine passes flowing, removal of the new catheter inserted. So again, you'll just talk about how quickly the urine is draining there. When you remove the catheter, you will obviously document why you're removing it, what the catheter tip and balloon looked like. So were they all intact? Was everything okay? Because again, if you've left some plastic inside the bladder, that's going to cause a problem. You would look at any discoloration or infections. You would talk about any problems with deflating that balloon, because what normally happens is on the Foley, that plastic bit, if you put the injection in there, it naturally will draw the water out. You don't have to pull it. It naturally will drain. And if it doesn't, there could be a problem with pressure. So again, it gives you an idea. And obviously, if you put 10 mils, did 10 mils come out? Patient discomfort while removing it. So it shouldn't be that painful to remove, but it can sting. So what we tend to do when we remove the catheter, we ask them to breathe in. And when they breathe out, we give it a little tug. So you're using the breathing activity to help with pain management. Yeah, so breathe in, breathe out, and as you breathe out, give it a little tug. Again, any bleeding you would report, and if any urine passed or followed through. So what we're looking for then, when we put the catheter in, we need to make sure that we have the catheter pack. That normally has everything you need in it. Disposable pads, that's for absorbing urine. You have your sterile gloves. So this is the aseptic technique stuff. You'd have your selection of catheters. You should have the right size and the right color. That's what should be prescribed. You've got your lubricating gel. So to gel or not to gel is the question. Most men will want anesthetic. Because when you think about the length of that tube it has to go round, that's quite a long insertion. And when we insert the whole length of the catheter. So the whole Foley goes into the rubber tip, and then we pull it out once it's inflated. So actually that's quite a journey. So if you are going to use lubricating gel or an anesthetic, we would squirt that in the urethra first and leave it about 5 minutes, 10 minutes for it to work. Obviously have your specimen container. So the moment you get fluid out of the catheter, you should take a specimen of that, do a dipstick. Sometimes they have to go off for sampling just to see if there's an infection or anything in there. Obviously your alcohol hand wipes for washing your hands, tape for doing the strap on the legs. And you normally have those stickers, the ones that go on the inside leg for the catheter to clip into. Do you know what I'm talking about? So normally you have the up on the high thigh of the leg, there's normally a sticker with a cap on it, and it holds the Foley in place, the tube, so it stops it from being pulled. Have you seen those? Okay, I'll show, I'm sure there's a picture on here. Obviously syringes for inflating the balloon and for flushing the catheter. So you need 2 different syringes, disposable gloves and aprons. And then you've got your sodium chloride for the balloon. So not saline, because the salt can damage the balloon. Okay. So suprapubic catheters, obviously the benefits of those is you're going straight into the bladder, so you're not damaging the urethra. The downside to that is it's surgery and you're going to have a port put in for the catheter to go in and out. So problems with suprapubic catheters, obviously all indications, anytime the urethral catheter is not being adequately drained, it can cause pain and discomfort. It's a bit more invasive in the fact that actually it's on the outside, where the other catheters normally attach to the inside of your leg bag, so they're a bit more discreet. So a bit more obtrusive, minimises complication with the urethral problems, and obviously better for draining. So advantages over the urethral catheters, they do decrease the risk of urinary tract infection because you're not using the urine tract. It's obviously easier to maintain. It's less painful and discomfort because you're not going down the urethral tract, you're just going straight into a port. And people patients prefer them. So the only downside is obviously you've got to have that surgery for it. The risks and disadvantages, obviously it can cause bowel perforations. You can get infections at the site of the port. They can cause a bit of pain and irritation. Bladder stones can form in the bladder. And that's because if you think about how the bladder sits, which is like that, and this is the urethra, all down here is where the sediment sits. Up here, like halfway in, is where the port goes. So it's kind of halfway up the bladder, meaning the bladder never fully drains properly with one of these. So actually that sediment could be starting to form stones at the bottom of the bladder. So that's what we're looking at. And obviously you can have leakage around the port site. Time is everything. So if the catheter comes out, it's important that the stoma site never closes up. So the stoma site on a suprapubic catheter can heal quite quickly, and therefore it is all about getting them to hospital and getting a new one put in as quickly as possible. And it is a two-person technique. So that's the sticker that I was talking about that goes on the leg. Have you seen those? No. So the idea of that sticker is you can put the date on it. So it means anyone knows when that catheter was put in. And what it does, it just holds the Foley in place. So it stops it being pulled. Because if you imagine, if that's got a urine bag on the end of it, it's going to tug, isn't it? It's going to really pull down. So it stops that pulling part. And you know the difference between the day bag and the night bag. So obviously the day bag's slightly bigger and the night bag's short and perfect. Equally, you will normally see this sign. So that number 2 means obviously it's not to be used more than twice, and it's just a reusable item. When you obtain a specimen, you need to use your aseptic techniques. The sampling pots should already be provided, normally by the GP. They normally give you the urine pots. If you're going to do it, you need to think about how you're going to use the syringe to collect that and any swabs, and ensure the specimen is transferred within 2 hours. So a urine collection, you need to arrange a pickup for that. So if you are going to do somebody's catheter, make sure you've spoken to the district nurses team or you've spoken to the GP on how that urine collection is going to be done. A patient's catheter drain. All right, we're going to worry about that one. So if a catheter doesn't drain, a couple of things to think about. First of all, are they drinking enough fluid? Second of all, are there any kinks in the catheter? So has the Foley bend? You need to look at feeding. So for the suprapubic one, the feeling of the need to pass urine, but they're not unable to go. So they've got that retention, they're holding it, they're just not relaxing. Because again, it's quite an unusual feeling to pass urine but not push. So it's about just relaxing and letting the catheter do what it does. You may need to reposition the catheter. So sometimes what you could do is push the catheter, push the Foley back down the urethra a little bit, twizzle it and then pull it back. And that reposition of the balloon may help there. If all of that doesn't work, you can then do a catheter washout. And that's where you inject 50 mils of water into the side of the catheter. So that's where the night bag goes, or the day bag goes into that tube. You would inject that with 50 mils of water. But the rule of that is whatever you put in must come out. So if you flush with 50 mils of water, you need 50 mils of water back. And you can flush it as many times as you need to until the water comes out clear. So, and again, you would discard the water. So you would flush once, withdraw, discard, flush again, discard, and so on and so forth. So it's quite easy to flush. And obviously, sorry?
If you put the water, so the water won't come back out clean.
No, so what you're doing is you're flushing the bladder. So what might happen is when the catheter bags become really cloudy and quite thick, what that tends to be is the sediment in the bladder is just sitting there in the bottom of the bladder. Because it's not going through the urethra properly, all of that sediment is building up. So you flush it with water, you flick the sediment around and you're drawing it out while it's still floating. That makes sense.
Yeah.
So you're just going to keep flushing until it's clean. And once it's clean, you know that actually that's that.
Yeah.
And then finally, if all else fails, if the catheter's still not draining, change the catheter, because it could just be that there was a manufacturer problem or something. So there all are kind of things about what's if it's not draining. So when you do a washout, it's often called a bladder washout, as most people describe that. It should be kept to a minimum only as you need to do it. So this isn't a thing that you do all the time. It's just as and when you need to do it. Some people require daily, some require weekly, some require fortnightly. It is personal centered. It's whatever's going on with their bladder is how many times you do a flush out. Usually it takes around a month or two to determine the frequency. So if they're new to a catheter, we would wait to see how bad it gets first before we start to flush. Because it may be that the bag fills up with sediment and blood in day one, but actually the next couple of days it clears up quite easily on its own. You don't necessarily need to flush out straight away. So you would wait to a point where you think, oh, actually, no, I do need to do something. But again, most district nurses would tell you, look, actually, yeah, do it, or don't worry about doing it. Never use a catheter tipped syringe. So we'll show you those, and always follow the care plan. When you do a catheter flush out, you can see these bags here. So sometimes you might have a bottle which you just attach and you squirt that in and it comes back out. You may have a catheter bag, a flush bag like this one down at the bottom. And again, that's already pre-filled. You just squirt it in to take it out. So then that's done. Alternatively, you might have 15 minutes of another solution. So it depends. Everyone seems to get a different thing. All you need to know is whatever I've got, a bottle or a bag or a syringe, I'm just going to connect it to the Foley, pop it in, and obviously make sure that what goes in comes back out. And it's designed to clear the debris and it just comes out clear. If it doesn't, you would just repeat. Okay, happy with that? Right, so I don't know. No, so what I need to do there, for the insertion of the catheter, there's training videos online. So on your Canvas login, you'll see how it's done. But basically, and it's quite difficult for me to explain it without showing you, but as you can see here, regardless of the penis or the vagina, you would clean the area first. You would find the urethra hole. So before you start any procedures, make sure you've got the urethra hole. We think about dignity. So we could have a towel down to catch any urine, and you would put tissue over the vagina and penis with a hole. So like you saw in the peg feeding where they put that blue sheet down with a hole, you would cover up the space that you don't need to see. And all you're going to do, you take the Foley, pop a bit of lube, and you're just going to push it into the urethra. And you just keep pushing it in and pushing it in and pushing it in. And what happens is you push it in until the tip of the catheter is reaching the body. Once it's reached the body, you would inflate the balloon by 10 mils. Normally, it tells you on the catheter how much to inflate it by, and then you pull it out until it tugs, and then you know that the catheter is inserted properly. So it is a really simple procedure. It's not difficult. It's just that you need to show that you can do it on a male and a female, because they are slightly different. But what will happen again, watch the videos in Canvas, because it shows you the techniques. And then when I come out, I'll bring the vagina and the penis with me. We'll have a go at doing it together, and then you'll do it. I know, because obviously I have penises and vaginas in my bag. It's what we carry around with us. And then obviously you'll get an opportunity to do it. And then once you're confident with doing that, again, if you then had customers or patients with catheters, you can do it alongside the nurse. So when the district nurses come in, you'll have a competency checklist. So I'll give you the competency statement pad. Once that's been signed off 5 times, you can then catheterize. But again, it's one of those skills, you just need to keep up with it. So if you don't really do catheterization in your home, it's going to be quite hard. But again, the idea of this course is it gives you the insight, it gives you the confidence to know what you're going to do. You just need to then get yourself more practices with it, because you're not going to use all of these clinical skills. For your end exam, out of the 15 skills, you only have to do 2. So it's whatever's relevant to you in your home. Are there any? Yeah.
Is this certificate will be for all the rest of our life, or
once you get your diploma? No, once you get your diploma, it's for life. Each skill, though, no different to being a nurse. So I still have to attend annual or 3-yearly updates. So I still have to do my updates, but my degree is for life. So no different to your level 5 diploma, it's for life. And what you will realise is all of the clinical interventions that you learn, you just do an annual update. And you can do an annual update online. It's just you keeping on top of, is there a nice guideline change? Is there a different technical procedure? Because actually the procedures are all straightforward. It's all that bit around it, around consent and capacity and all of that. Okay. So that's that one. And you will find again, via your online canvas, all of the videos